Thank you, Ed. Thank you for having me. Good morning, good afternoon, good evening, wherever in the world you are. Thank you for coming. I'm going to give a bit of a beginner's guide because I know there's a lot of people new to this therapy, and I appreciate that some of you have seen me before, but I'm going to do more of a beginner's guide to this photobiomodulation for orofacial pain. Disclosure, first of all, so I'm founder CEO of THOR. I've got shares, salary and expenses, and I've co-founded another light therapy company. So I am extremely biased, and you can't believe anything I'm going to tell you today. I started life as an engineer, so I'm not a scientist or a doctor. So you can't trust me, and I don't know what I'm talking about. Anyway, I have been doing this a long time, for 33 years, so since 1987. Yes, I know, just look at me. I obviously started when I was 5 years old. So I've co-authored 22 academic papers, 6 of them with Harvard Medical School. I've co-authored 4 academic books on this subject. So my expertise, my reputation is all about dose and beam parameters, which we're not going to do much of today. I've been an expert reviewer for the journals that publish most of the work in this field. I'm a co-chair of the Biomedical Optics Society Conference on Photobiomodulation Mechanisms, and I've joined a couple of other interesting clubs. So a lot of our collaboration has been with folks around Harvard. So at Harvard School of Public Health, we've been working on noise-induced hearing loss. Brigham and Women's Hospital, working on children with cancer, and they have bone marrow transplants and whole body radiation, and they get a lot of side effects, one of which is oral mucositis, and I'll be showing you some data about that later on, but also working at MGH on the world's leading cause of death and disability of children and young adults, which is traumatic brain injury. At least it isn't so in the developed world. Already they're treating patients at the VA in the United States. At Cornell, been working on cancer safety. You know, does this therapy stimulate the growth of tumors? Does it reduce the growth of tumors? Does it have no effect at all? You know, been working on dose response with NYU. More head and neck cancer side effects, and particularly that means in and around the oral cavity. So things like oral mucositis and hypersalivation, for example, dysgeusia, dysphagia, so lack of ability to swallowing problems and problems with taste. Sports injuries in Brazil at Unifes, University of Barcelona Dental School, a lot of things coming up from then, as you'll see. St. Jude's, the world's leading research center for catastrophic diseases in children, so they're treating oral mucositis as well. At Einstein University, they've been working for researching solutions to plutonium poisoning after a nuclear war. So if you're not blown up by the bomb, the next problem you've got is the plutonium fallout. And so what they do is they do experiments where they expose mice to gamma radiation, and it will kill 80% of the mice. They only have about 20% survival. But if those mice get our treatment within 30 minutes, we can double survival from 20% to 40%. And if we can treat them prior to exposure to gamma radiation, we can increase survival to 60%. How cool is that? And you'll see why that's relevant, particularly for head and neck cancer patients as well, later on. So Hebrew University, working on anterior knee pain, Memorial Sloan Kettering, graft versus host disease. You may see some patients like that, a reaction to a bone marrow transplant. Nova Southeastern, chemotherapy-induced peripheral neuropathies, treating acute myocardial infarction. We're not showing you that today, unfortunately. More oral mucositis in Brazil, chronic pain clinics in the United Kingdom, in our National Health Service, cancer therapy side effects in children again. And last year, we finished a large multi-centered clinical trial, head and neck cancer patients, treating the side effects and specifically oral mucositis. So now we're in about 55 different academic institutions around the world. All the yellow highlighted ones are all cancer related, and all the pink ones are sport related, and various other projects going on. And this is all photobiomodulation. Who knew it was such a big topic? Well, you just wait and see. So my plan for you for the next, for the remaining 55 minutes is, well, do this overview of what this field is, how it works. I'll run you through some of the, I'm going to give you like one slide, give you 1 minute on dose, to tell you, just to tell you it's important. We'll talk about the common applications not related to the oral cavity. Then we're going to get into dental applications, and then safety and contraindications. And then we'll draw it to a conclusion. Now, if you're really new to this and you don't know why you signed up for this thing, this next slide is for you. It sums up everything you need to know about this therapy. And when you've seen this slide, you can kind of tell your friends, you can sneak off and do something else and just say, hey, I understand photobiomodulation. It's amazing. I've seen the light. But this is your slide coming up. You just need this one, and that's all you need to see. Basically, it's a bit of video I've stolen from an old-fashioned TV show your grandparents used to watch called Star Trek. On Star Trek, when somebody was injured and they went to the sick bay, the doctor would aim the laser at the injury and the injury would heal instantly. So we make those.
Live long and prosper.
It's Mr. Spock, just in case you're not old enough. Okay, that's photobiomodulation. And it's not as fast as on TV, but you get the idea. We shine light on people and they get better more quickly. Unfortunately, this therapy's had a lot of different names. And if you've ever looked into this subject, you've probably seen some of them. And I say a lot of names, I don't just mean this lit here. There's more than 100 different names for this therapy, unfortunately. And many academic papers don't even give it a name. They just say something like 810 nanometer, 200 milliwatt pain relief. I mean, how do you find that if you're doing literature reviews? It's difficult. So we actually use 300 different search terms to gather all the literature that we're interested in, put it into our databases. So the leading term on the internet, or specifically PubMed, the American government database for medical research run by the National Library of Medicine, the leading term up until 2017 was low-level laser therapy, or LLLT for short. And sometimes it was called low-level light therapy. But it's widely agreed that that's not a good name for the therapy, partly because it doesn't have to be a laser in order to work. We can use light-emitting diodes as well. It doesn't sound great when you talk to your patients and say, would you like a low-level laser therapy treatment? You know, not inspiring, right? And it's a bit of a tongue twist for you and your patients and any observers to go around saying to each other, you know, oh, low-level laser therapy, LLLT all the time to each other. So it was decided that a much shorter, more succinct, patient-friendly term should be adopted. And that's how we ended up with photobiomodulation therapy, which obviously isn't a more patient-friendly term, but it better describes what this therapy is about. So photo means light, bio means life, and modulation means we can stimulate or we can inhibit. We can slow some things down. And already the press, the academic press, are calling it PBM therapy or PBMT. And PBMT has already been accepted by the National Library of Medicine as an official mesh term, a medical subject heading, okay? So photobiomodulation, PBMT are really the official terms for this. So what is this therapy? Well, it's the application of monochromatic light, which means light of one color. And if we have light at the right color, and if the light is at the right intensity, and if we aim it in the right place for the right amount of time, we can increase the speed and quality of tissue repair, we can reduce inflammation and edema, we can induce an analgesic effect. Most of the published clinical evidence is on musculoskeletal pain, so sprains and strains and creaky joints. But there's also some applications for its effects on neuropathic pain, like shingles and postherpetic neuralgia and trigeminal neuralgia, chemotherapy-induced peripheral neuropathies, diabetic peripheral neuropathies, hard to heal wounds like diabetic foot ulcers and venous ulcers and pressure sores, breast cancer-related lymphedema. They also tell me it works for primary lymphedema and lipedema as well. And fibromyalgia and other difficult, as you're going to see later, and difficult neuropathic, who knows, neuromuscular, myofascial forms of pain, things like chronic regional pain syndrome, CRPS, very difficult. I think there's a version of that you can get with a tooth extraction. Certainly happens in the lower limb surgery, for example, knee replacement and the like. People have fractures in their foot, for example. Awful. Anyway, in dentistry, these are common applications. I've got a much longer list coming up for you shortly. But oral mucositis is probably the most researched application. There's already 47 randomized placebo-controlled clinical trials published on photobiomodulation treatment of oral mucositis. Otherwise, obviously treating post-surgical pain, temporomandibular joint dysfunction, speeding up the movement of teeth on patients wearing orthodontics. And then it's also being used in a wellness sort of context for healthy aging, people using it for wellness, their strength, endurance, and recovery after exercise, and eternal life. kidding. Anyway, our device looks like this, and you're going to see some, I think there's a showcase about our products coming up one of these days at this event. And it's a console. We have lots of different accessories we can apply to it, including intraoral treatment probes and myofascial trigger point probes and clusters of lasers and LEDs you can use extraorally. This new giant laser cluster probe, which covers a very large area, it's got 80 lasers in it, and a probe that treats the whole of the oral cavity in 1 minute. So our lollipop, as we're calling it, popsicle if you're American. So, and something I'd like to talk about in more detail, but this is a 1-hour show, is our 4-step treatment method, but there isn't time today. But I'll just mention this bit. We aim light at the injury and it helps it get better. So in this example, it's a tennis elbow. We'll put some light over his lateral epicondyle to reduce inflammation and to promote repair. But we can help this along if we also treat the lymphatic system. Now apply this to your mind for in and around the oral cavity. You can think about your, your parotids and your submental lymph nodes and cervical lymph nodes as well. So think about that. So yeah, we can treat lymphatic system to help drain inflammation away. The patient's going to be in pain, so we like to treat over nerve roots in the spine, and you can treat some of the cervical nerve roots to have some of these effects as well. And as well as treating along the course of a nerve as well, and treat myofascial trigger points, like if you're treating TMD, for example. LINT, lymphatics, injury, nerve, trigger point, LINT, lint. It's a word that helps me remember my 4-step treatment method, okay? I appreciate, some injuries, or really not injuries, they're diseases, they're degenerative diseases like osteoarthritis, and therefore we should really say pathology, LPNT, though it's not pronounceable. I needed a vowel, just so it said lint, so you'll have to forgive me using lint. And here's some pictures of treatments in and around the oral cavity here. So we sometimes treat intraorally, sometimes treat transcutaneously through the cheek to get light to the buccal tissue, say in a cancer patient with oral mucositis. Sometimes we pour light into a joint, for example, maybe helping regenerate the nerve, the inferior alveolar nerve after a iatrogenic injury, so you can treat the mental nerve there. Hopefully, well, a lot of you have already figured out that this is not a heat therapy. The effects are more like photosynthesis in plants, because humans and animals will photosynthesize. And this is something you already know, but you may not have thought about this before in this same way I'm going to present it. But you know that when you go out in the sun, you change color. And you might know that you use sunlight to help you synthesize vitamin D. And you might know that they use blue light on prematurely born babies to prevent neonatal jaundice. And you may know that they use ultraviolet light in dermatology for treatment of psoriasis and vitiligo. So you shouldn't be surprised if light has some other effects on the body. Now, normally you would think, and particularly with the ALD, you would think of lasers in medicine and dentistry as being used for cutting and ablating, cauterizing tissue. Well, not all lasers are dangerous. And that's because there's different classes of lasers. And if you're part of ALD, you ought to know this already, but you know there's class 1 lasers that are used for maybe my lecture pointer here, or maybe used in barcode readers, for example, and nobody gets hurt. So lasers are around us all the time. They're not necessarily dangerous. The classes that most people, like your patients, think of in medicine and dentistry are the class 4 lasers. These are the ones that have a thermal effect. We mostly use class 3B lasers. They have no harmful effects on skin or clothing, but they are, at least in theory, potentially hazardous to the eye. We also use light emitting diodes, LEDs. They've got some similar qualities to lasers. And so for most of this presentation, I'm going to be talking about lasers and LEDs as if they're exactly the same thing. But because we're using these low intensity lasers and LEDs, they mostly do have the same effects. There are times when you prefer to use lasers and LEDs, and I'll see if I can remember when to point some of those out to you later on. And I will be at the very end letting you know how you can actually come do my full 8-hour training course as well, where we go into these things in a bit more detail and we spend more time on things like laser safety. I know you probably covered it if you already an interest in lasers and dentistry, you know a bit about safety already, but it's something we cover properly in our training course for 3B lasers. A little bit of history for you. This therapy starts with Albert Einstein and seems to end up with me. This is a great slide, isn't it? Einstein had this theory about stimulated emission, light amplification by the stimulated emission of radiation, LASER, laser. I know most of you know that already. In 1960, this gentleman here actually built and patented invented, built and patented the world's first laser. Yes, Kathleen, his wife, made me sure I got all three of those things right. And then in 1967, Andre Mester here wants to find out if it might cause cancer. He takes a group of mice, he shaves the hair from their bodies, he divides them into two groups, he puts a low-powered ruby laser beam on one group and not the other to see if the treatment group developed cancer, and they didn't. And to his surprise, the hair grew back more quickly on the treatment group when compared with the untreated group, and he called that effect laser biostimulation. I'm going to jump through this because we can't afford to wade through all of this in slow motion. But reputable organizations, the World Health Organization, the Lancet, the American Physical Therapy Association, the International Association for Study of Pain, British Journal of Sports Medicine, British Medical Journal, these are all reputable institutions publishing systematic reviews saying things like strong evidence for myofascial pain syndrome, strong evidence for its treatment of frozen shoulder. So this is being taken seriously by serious academic groups now. And if I sort of jump down to the bottom down here now, insurance companies in the United States are declaring this therapy medically necessary for oral mucositis, as an example. And hopefully they'll be starting to pay out soon for this. So now there's more than 700 randomized placebo-controlled clinical trials in this field, more than 4,000 laboratory studies looking at the mechanism of action and the dose response. Last year alone, there were 500 papers published in this field. That's about 42 every month. In total, 7,000 papers published in this field. And now with our products, we've calculated them, and actually we've delivered 30 million treatments so far. And of course, this work's been published in some journals you've probably heard of. Now, you probably caught on that it's got a rather broad range of application. How can one medicine treat so many different conditions? Well, it's because it all starts in mitochondria, which a lot of you know of as just being the powerhouse of the cell. And in my long 8-hour course, I didn't mean this to be an advert for my full training course, but this is a good hour's work just to talk about how light affects the ability of mitochondria to produce ATP and reduce oxidative stress. Did you know that when you're sick, when you're injured, when you're stressed, and just gradually as we get old, our cells tend to be low on energy, low on ATP, and they tend to be high in oxidative stress. And simply, this laser tips the balance in favor of more energy, ATP, and less oxidative stress. And under these circumstances, patients start to heal more quickly. So here's some biomarkers for those of you who are nerds. There's all these cytokines down here and gene transcription factor, which is mostly responsible for these changes and leading to less inflammation, less necrosis. And up here, all these positive things are happening. So TGF-beta very much involved in triggering tissue repair and activating stem cells, for example, and Treg cells are as well. So these are all either anti-inflammatory and or start regulating and stimulating the tissue regenerative processes. And then there's this map of what happens, this cascade of events after light's absorbed by cytochrome C oxidase in mitochondria, a cascade of events that occur, all these cell functions that change that lead to better healing, reduced edema. Oh, got another click to come in here. Yes, we'll pop that in there. Because this is very good at affecting blood flow and lymphatic flow, and it seems to enable or assist the collector vessels in the lymphatic system to take inflammation away. It's one of the other mechanisms involved in inflammation. And then there are these analgesic mechanisms as well. So a lot to talk about here, which we're not covering today, I'm afraid to tell you. So, and there are other mechanisms, not just the cytochrome C oxidase story. We are quite aware that this therapy has some effect directly on cellular membranes, membrane permeability. That's very clear. The TGF-beta 1 mechanism, not clear yet. other postulated things. I have to mention this because, like I said, I'm a co-chair of the Biomedical Optics Society conference on photobiomodulation mechanisms. Other thoughts are in the works, not confirmed necessarily yet. I also told you there is a dose response. Not enough light, you don't have an effect. Higher levels of intensity, you get bigger effects. If the light intensity is too big, you begin to lose effects as well. So there's an intensity and treatment time dynamic here. You've got to get enough intensity, but not too much. And you've got to use it long enough, but not too long. And just to give you some idea, typically that's around 30 seconds to a minute per area you want to treat is the kind of treatment time. And the intensity, the irradiance, well, for superficial tissues, you really want to be probably 50 to 100 milliwatts per centimeter squared in that zone there, unless you want to kick in some other mechanisms, which I'm going to be mentioning later on. So there's this therapeutic window you mostly want to be in for anti-inflammatory effects and regenerative effects. Oh, I thought I'd taken this out, but I hadn't. Anyway, just as a study on blood flow, it's fascinating. In this experiment, they're going to put red LED light on the wrist, or red and near-infrared. They're going to show increased blood flow to the hand. What makes the study interesting is, though, the opposite hand has exactly the same effect. Turns out your sympathetic nervous system is different from, say, your sensory nervous system. If I hit my thumb with a hammer here, it hurts the left thumb. It doesn't hurt this one, does it? No. So they're separate. But that's not true for sympathetic nervous system. You stimulate one part of the sympathetic system, it affects the other side, apparently. Who knew? Well, this study did, because look at this. These are their hands before they have LED treatment to the wrist. Treat one wrist, they treat this one. Here's a bit of white there where they're applying the light there. And both hands have an increase in blood flow simultaneously. Interesting, huh? And it's one of the other mechanisms involved in this therapy, improving oxygenation and all those goodies that get to the site of the pathology. So common applications outside the oral cavity, regenerative ones, for example. This patient's diabetic, he's had a hernia operation, and a year later, his wound hasn't healed. This is Rochester General Hospital. The dermatologist puts the light on, LED light, onto the wound, and then there's good signs of healing. No, that wasn't instant like on TV. That's probably about 2 months old. Haven't been treated. But remember, it hasn't healed for a year, so that's good. There are research papers on diabetic wound healing showing improved healing rates and granulation tissue when compared with controls. This is pressure sores. It's 6 centimeter deep. He's had it for 2 years, a 6 centimeter deep cavity. Course of treatment, it's down to 3 centimeters in 5 weeks and fully healed in 7 months. Keeping in mind that it had this sore for 2 years and it wouldn't heal. It was costing about twice the price of the product each year just to look after that patient. Venous ulcers, another hard to heal wound here. Now, the videos is a camera, it's already healed. They just brought him back in to show the news company what LED photobiomodulation can do for wound healing. But anyway, that's all new skin. He'd had that ulcer for 10 years. And there's randomized controlled clinical trials on ulcer healing. This one here showing no significant change in the control group, a significant reduction in the wound area, particularly in the first 4 weeks here, with LED photobiomodulation applied. It works on acute wounds as well. This gentleman here got a new toy for Christmas from his wife. You can see the date, and you can imagine what he's done. And then a week later, it looks like that. And then a month later, it looks like that. And here we are. What's that, about 3 months later, 3.5 months later. So this is a postoperative wound. It's a total knee replacement 3 days after surgery. And there it is 3 weeks later. There was a bit of a scar you can see down there, can't you? And burns. There you are. 2 days after treatment, 4 days after the original burn. There we are, a week and a day later. Incredible, huh? Yes, fresh new skin looking lovely, those still tender, which is to be expected. Right. Edema. So these are second-degree ankle sprains in soccer players. They put their foot in a foot volumeter, they measure the displaced amount of water, so it tells them the volume of the limb. Then they get randomized to 3 groups. They get rest, ice, compression, elevation, RICE therapy, they call it, RICE plus placebo laser or RICE plus active laser. And the greatest reduction in limb volume is in the photobiomodulation treatment group. So it's anti-edematous as well. It's regenerative. Here, this is a fracture that wouldn't heal after 6 months, should have been plated. Osteopath straps up the arm, treats the clavicle there with the laser, and then 3 months later, so they've got a course of treatment, 1 treatment a week, and there's good signs of union now. And there's a randomized controlled clinical trial on fracture healing here, showing improved grip strength in the hand and the finger when compared with placebo control. So this is signs of regenerative effects in the wrist and hand fractures. Nerves as well. These are soldiers who have gunshot wounds to their peripheral and brachial plexus nerves. These injuries are at least 6 months old, some of them several years old. No significant improvement in the control group, but a significant improvement in the active treatment group. And here we are with a dental one. I was going to keep my dental ones together. How did this get in here? Anyway, yes, inferior neurosensory recovery after injury to the inferior alveolar nerve. They do a brushstroke discrimination test here, so they're getting a very low score. I don't know how they do it. Presumably the patient closes their eyes and they brush the cheek one way or the other, or up or down, something to identify what the patient can distinguish. They got this very low score here, and then they get a course of treatment 3 times a week for 7 weeks, 20 treatments in all, and you can see this wonderful recovery in this patient here. More regenerative effects. People are using it for regrowing their hair here. Apparently 3 sessions, and then, well, sorry, after 3 sessions and after a 6th session over there. So apparently a happy customer. Maybe you want that as well. Anyway, anti-inflammatory effects. This experiment is on patients who have an Achilles tendinopathy. They put a catheter into the Achilles tendon sheath, and they're going to do this microdialysis measurement for PGE2 concentrations. And they're going to take this measurement every 15 minutes across here. So at this point here, I think what I forgot to say is they make them do exercises. Did I say that? The exercises are designed deliberately to aggravate the injury. This is an activated Achilles tendonitis. So they come along, do the exercises, they put the catheter in, they take a measurement, they get a laser or a placebo treatment. In the placebo group, the inflammation goes up because, well, an hour previously they did the exercise, so inflammation is going up. But in the active treatment group, who also did the exercises an hour previously, their inflammation is going down. This is objective evidence in humans which you just cannot ignore. This treatment is highly anti-inflammatory. Notice it goes up before it goes down. In case I forget to mention it later, when people talk about thinking, are there any side effects? Well, there are no known side effects, but you can get these treatment reactions, and sometimes the inflammation goes up before it goes down. They say, ow, you may be an hour after treatment or something. So it's temporary, lasts hours, it doesn't last days. Okay, so it feels worse before better. But anyway, here's objective evidence in an Achilles tendinopathy of a reduction in inflammation. Osteoarthritis, enzinitis, anything ending in anitis is a good application for PBM here. And so this is a systematic review published in the British Medical Journal here. 22 randomized controlled clinical trials systematically reviewed 1,063 patients. They gain 18 millimeters of pain relief. Okay, so I hope you're familiar with the visual analog scale. I'm sure you are. 18.7 millimeters. How good is that? Apparently for musculoskeletal pain, typically non-steroidal anti-inflammatory drugs will get you 7 to 14 millimeters. Here they get 18 millimeters at the end of the study. But if they follow patients up to 12 weeks, and their relief improves to 23 millimeters. And then there's this magical moment about 2 to 4 weeks after treatment where it goes to 31 millimeters of pain relief, 31.8. This is huge. This is a big deal just by shining light on it. Disability also statistically significantly reduced. The positive effects of PBM lasted longer than widely recommended drugs. no adverse events reported. How cool is that? And it's interesting that they got the pain relief, the best relief 2 to 4 weeks after. And we see this in other situations. You start the course of treatment, you finish the course of treatment, and you've started a healing cascade. Patients continue to get better. Myofascial pain, for example, you'll get that with TMD, you know, masseter muscle, temporalis, neck pain, and, you know, trapezius. Yes, The Lancet, the world's leading journal for breakthrough medicine, published a systematic review of photobiomodulation for neck pain, which is substantially myofascial pain. I know a lot of you struggle with this. 16 randomized controlled clinical trials, 820 patients in the review, mean duration of symptoms 7.5 years, plus or minus 3. And they were able to demonstrate that laser reduces pain intensity, reduces disability, reduces recurrence. They found more evidence supporting use of laser than any other intervention. They reduced pain for between 19 and 86 millimeters of pain relief. And the mean pain intensity reduction over placebo is 23.4 millimeters, which is huge. And they found something not quite as grand, but still good for low back pain. I'm sure many of you struggle with that. Another systematic review in the British Medical Journal here, 15 randomized controlled clinical trials, 1,039 participants, moderate quality of evidence, clinically important benefits, significant pain reduction in trials using at least 3 joules of energy per point on patients with a duration of back pain that was less than 30 months. Now, I said I'd tell you something about this analgesic mechanism. And that I'd say something else about dose. So here it is. In this experiment here, which is going to be on rats, they're going to inject turpentine into the paw of a rat, and they're going to attach an oscilloscope to the other end of the saphenous nerve, just outside the exposed dorsal root, and then they're going to switch on a laser beam. So this is the point where they inject turpentine. This is over a period of 1 minute, okay? In goes the turpentine, out says the rat, on goes the laser beam, instant analgesia. In this experiment here, they're going to electrically stimulate a tooth of a rat, and they're going to put a probe into the brain to the trigeminal ganglion. They're going to measure the electrically evoked potentials. Then they switch on a laser beam onto the tooth, and they substantially reduce the electrically evoked potentials. And here is a patient who needs to have a second molar extracted, doesn't want any anesthetic, is just going to have a laser treatment. Yes, a laser anesthesia. And just let you watch this. There you go. It's already been luxated. It's just coming out now. No anesthetic. And that's my tooth. Yeah, that's me. Can you see? You can tell. So that's my tooth. How did I do that? Well, first of all, subsequent to that, I've been for the first and second stages of an implant. First and second stage. It's Aaron, who's probably going to be watching this, trying to remember how many stages have I had. I had the bit where you drilled the hole and we screwed in a bit of metal, and you sewed it all up, and now I went back and you cut the tissues and you put something else on top. That's right, with a pillar that's there now. Yes, so we've had the second stage as well. So we've had several chances to experiment with this. First time wasn't very good. I was using 30 seconds per point. You know, I tolerated it, but as Aaron would tell you, he could tell I was obviously struggling with it. It was not nice. I wouldn't recommend it by itself, but then we went to 3 minutes per point. That was a lot better. So I'm treating along the inferior alveolar nerve through the bone and along the long buccal nerve there. And I was so excited when Aaron went and cut the soft tissues. First of all, I was getting numbness this time, proper sort of paresthesia, lip and chin, and along the lateral border of my tongue, a bit of numbness there. Not as profound as if I'd had a lidocaine injection, but I could tell something was working, and he cut the soft tissues and I felt nothing. And then he goes to drill the hole into the bone, and I felt nothing apart from vibration, of course, of the drill. And then he screws in the implant. Now the pain starts to come back about after 20 minutes, but Aaron topped it up. We sort of treated either side of the second molar, and that lasted for another 20 minutes, and the whole procedure took about an hour, so it needed to be topped up twice. And only really the significantly painful moment was when it was that last sort of half or quarter turn of that wrench when he's screwing the, when he's putting the implant in. And he said, "Oh, shall I zap it again?" I said, "No, just finish off." There we go, had that done. Now, Barcelona Dental School, on hearing this, did an experiment on palatal injections where they would give a 2-minute 810 nanometer 200 milliwatt laser treatment to the site of the palatal injection, and they give a placebo one to the other side. But it's randomized. It's a controlled clinical trial for patients who are having bilateral palatal injections, which I'm told are painful. And what did I say? They treated for 2 minutes on one point, and the pain reduction for the injection was about 50%. Now, it's not published yet, so we'll see what the real hard data looks like when it comes out in a paper. Very interesting. So, I mean, 50% is something. Would have been better if they'd treated for 3 minutes, not 2 minutes. If they'd tried to treat along the course of the nerve a bit more accessible, obviously, around the mandible, we're able to get a better job. But if you have needle phobic patients, then this is something. They may not recognize it as being, I was probably overexcited just because, you know, I can't believe it worked at all or as well as it did. And people are used to a better kind of pain relief. But if you've got people who really want to avoid an injection, this is a really something you can seriously consider using. So, all right. I know I've started getting into orofacial pain already, so that kind of leads us in here now. So this is, postoperative neuralgia. See, this isn't in the mouth, but I want to show you this because I'm going to show you a PHN on the face later on, be coming up. PHN, postoperative neuralgia, is one of the worst kinds of pain that you can get, typically around the thorax, but people can have it on the face as well. So this is mostly thorax here. These patients have had it for a minimum of 6 months. The mean duration in this study is 2.5 years. They're only going to get 1 treatment a week for how many treatments they're going to get? Oh, 4 weeks. I can see it down here, 1 treatment a week, 4 weeks. This is not a lot of treatment in my book. I generally recommend twice a week is good. You know, I say my mantra is twice a week is good, daily is better. Anyway, I know it's not practical for your patients to come. You don't have the time, they don't have the money. So twice a week is ideal. And this is a 1 week, once per week treatment. But here we go. The pain comes down in group A on 1 treatment a week. No significant change in group B, which is placebo. But it's a crossover trial. So group B then get the active treatment. Group A go on to placebo. And notice their pain doesn't get worse. How about this though? 95% of patients discontinued all medication. Just 1 required a reduced dosage at the end of the study, the 1 month follow-up. At 6 month follow-up, 16 patients, that's 80% of patients, maintain their pain reduction. 2 patients returned to a pain score of 4, not requiring medication, and 2 patients returned to pain scores of 6 and 8. How cool is that? For one of the worst kinds of pain that you can get, that drives people to suicide. I think you're going to get all the right slides, just in the wrong order. Here is the list of potential oral applications for photobiomodulation. So I've broken down in sort of neuropathic pain and other forms of dental pain, regenerative conditions, and then there's a long list of things that possibly don't fit into any of these 3 categories. I'll give you a second to sort of cast your eye over that. We're going to go through, I don't know, half a dozen or so of these, so you get some idea of its capability. So top of the list for photobiomodulation inside the oral cavity is oral mucositis. So here, side effects from high-dose chemotherapy, high-dose radiotherapy, and hematopoietic stem cell transplantation. So let's show you 2 out of the 47 papers that are out there. So these on what the oncologists call, medical oncologists call transplant patients, hematopoietic stem cell transplant patients. These are the 5 grades of oral mucositis on the WHO scale here. Obviously 4 being the worst. When most patients, this is the number of patients who have it, so 10 patients in this study were at grade 4. Only 1 patient who was in the active photobiomodulation group got grade 4. Nobody on photobiomodulation got grade 3. Now you're beginning to see that all the, or most of the patients who get in the active treatment group are grade 2, grade 1, or none at all here. Whereas those who in the placebo group are shifted towards that end of the scale. You see how the scale works. And there's something over here called a Kaplan-Meier plot, which gives you some clue as well. And then head and neck cancer patients, radiotherapy, chemoradiotherapy patients. These are pain scores here. You can see this is the placebo group. This is the active treatment group here. And generally, we try to get people to treat concurrently with their radiotherapy and or their chemotherapy treatments to try and prevent it. We're finding that prevention is better than cure. Yes, there's something we do to tissues before they're injured that somehow they become more resilient. We've seen this in the lab. We get some cells in culture, we apply some light to them, they don't do anything. You try and kill them with some X-rays or some LPS or some methanol or something like that. And if they've had photobiomodulation before they're being poisoned, they are much more resilient. They survive better than in a control group. And we're seeing this in humans now in human clinical trials like this. Sort of a preventative treatment, prophylactic treatment. And again, to give Aaron Dabar his dues, he was pioneering this thing. He was coming on my training courses, I don't know, 20 odd years ago, telling me, you've got to get into dentistry, James. So there we are, and he was right. I'm sure he's done, I think he's already done his presentation on PBM. So there you are. Reduction in pain means that you get more compliant patients. So many patients want to give up their treatment. And even if they don't give up their treatment or reschedule their treatments, they certainly eat better, which is important. And you'll see why later on. Got something to say about that coming up. And the prestigious journal in cancer, this International Journal of Radiation Oncology here, published a review of some data that was from UPMC, University of Pittsburgh Medical Center. You'll be seeing Annette Quinn after me presenting her experience. She's got a lot of patient stories to tell. I don't know if she's showing this data as well, but basically they showed that when they introduced our treatment to her department, they reduced the incidence of grade 3 oral mucositis from 40% down to 10.5%. And there's a lot of applications around cancer patients, hypersalivation, dry mouth, radiation dermatitis, where the radiation goes in and what it does to the skin, swallowing problems, radiation fibrosis, head and neck lymphedema, breast cancer related lymphedema, not your department anyway, graft versus host disease. Did I show you that already? I can't remember. Anyway, so a lot of applications around cancer patients. Here's some before and after pictures. So this is done therapeutically rather than the other. So prophylactically, that's it. So therapeutically, after they develop the symptoms. So oral mucositis, before and after. Radiation dermatitis, before and after. Xerostomia, dry mouth, before and after. And it's better that you treat the saliva glands before the radiation if possible. And then people are treating typically 3 times a week. So they have a fraction of radiotherapy every day of the week, typically for what, up to 40 fractions. And if you can get in there every, a few times a week, you should be able to prevent this from happening. Here we are. So GVHD, graft versus host disease. So this kid's had a bone marrow transplant. This is a late stage effect. It comes along later and they develop this. They try to give it steroids to slow its development. It doesn't seem to work very well, but give them some photobiomodulation. The kid just gets his tongue out, aims an LED cluster probe into it, sort of like this. Okay, just over the tongue. I can actually switch it on here. I can actually do that. Yes, okay. Having said that, we've got a new probe I just told you about earlier, a lollipop. Put this in. Should have put a sleeve on that, but hey, there we go. So before and after, this was 1 treatment a week for 8 weeks. Should have been twice a week in my book, as I keep saying, but this is fantastic. The Multinational Association for Supportive Care in Cancer now recommend photobiomodulation for head and neck patients and stem cell transplant patients and chemoradiation patients. And in the United Kingdom, the National Institute for Health and Care Excellence now recommend photobiomodulation for head and neck cancer patients. And in the United States, Blue Cross Blue Shield, this Healthcare Service Corporation, Aetna, CMS, are recognizing that this is an important application of photobiomodulation. They've now declared it medically necessary. Not sure who's getting how much money for what at the moment, but for Americans who understand this, there are some numbers, codes for you. Ask Sarah Jane when you connect with her somehow through these seminars this week. I'm sure you're going to bump into her online somewhere. And yeah, we're in a lot of institutes in the United States in various research projects that will gradually, hopefully, establish this as a standard of care in the United States for oral mucositis. And if you want to read up some more on it, there's a couple of papers you should get. Judith Zika's paper here on mechanisms of action and dose response. This is, again, for head and neck cancer patients. And part 2 is all about the proposed applications and the treatment protocols. And there's some treatment guidelines as well in there, which are my contribution to this paper. And here's a picture of treatment it's actually Boston Children's Hospital, or Children's Hospital Boston, whatever it is, part of our Brigham Women's Hospital study, projecting light transcutaneously through the cheek into the child to get light to the buccal tissues, labial tissues, submental lymph nodes, cervical lymph nodes as well. And I've already shown you the lollipop, which I think those two combined would be optimal. And that's light-emitting diodes, by the way. And just in case I forget to say it later on, I know it depends which state you're in. If you're in the United States, and there are some areas where nurses are not able to apply laser treatments. A lot of our product is actually LEDs, light-emitting diodes, and a nurse can use those. Burning mouth syndrome. I know you don't want to rush towards these patients, but you're sitting in an orofacial pain presentation. So this is some examples, some very difficult conditions that are hard to manage here, showing that this is a course of treatment. Let's have a look at written it down here. Twice a week for 5 weeks, 10 treatments in total. Here we are, reduction in pain in the active group compared with controls, 1 month follow-up, 4-month follow-up. Not bad. Really? How many drug therapies have residual benefits months after you stop taking the drug? It happens quite a lot with photobiomodulation. TMD here. These patients have had TMD for a minimum of 6 months. They've been through standard care. So what's that? Dental splints, medication. If they fail to respond to standard care, they get enrolled into this study. They get randomized to 2 groups. They get 5 photobiomodulation treatments using our 4-step treatment method, like I described: lymphatics, injuries, nerves, and trigger points. And then this data is 2-week follow-up data. There's a significant reduction in pain in the active treatment group. There's no significant change in the control group, the placebo. This is interesting. There was, I think around about 2009, a dentist did an experiment on patients who were scheduled to have orthodontics fitted. As part of the procedure, they were going to have 4 premolars extracted. Instead of doing that, the dentist drilled 4 cavities, 1 in each of the 4 premolars, lasered 2 of them with photobiomodulation, didn't do the other 2, waited 2 weeks, then pulled the teeth, fitted the orthodontics, looked at the teeth under a microscope, and those that had the photobiomodulation treatment had increased tertiary dentin in them. And then Praveen Irani, who's a name a lot of people around ALD are aware of, did an experiment to try and elucidate the mechanism of action. And he showed that photobiomodulation activates stem cells which are resident in tooth pulp. How about that? You have stem cells in your tooth pulp, and they go off and differentiate into odontoblasts, and then they make new dentin. How cool is that? And I'm going to show you something else, which is, sorry, that wasn't really it can be painful, of course, you have that. This probably hasn't got much of a pain related thing to it, but I should have, this is about 3 years old, 3 years old paper. And I'm surprised I haven't actually used this slide before, but I just think it's so impressive here. So the gingival papilla regeneration. So looking at these black spaces, the gingival embrasure spaces here, you can see them now. What do? They take one of those, one of your perio probes and start poking around on the margin there of the teeth, and they so that they actually cause some bleeding. And there you can see it all around the teeth here. They do photobiomodulation on just above the gingival margin there. And what happens over a course of time? Look at that 3 weeks later. Isn't that amazing? Oops, I've repeated my burning mouth syndrome. You didn't see that, nor that one, because that's a repeat, and that one I've duplicated. Right, some slides, sorry about that. Yes, this persistent idiopathic facial pain, very difficult. What this is just a case series, really, of 16 patients, and really just looking how much, I mean, they've got slightly different diagnoses here, and they're going to get one treatment a week for up to 10 weeks, but they could stop whenever they liked, either because they felt like they're better or because it's not working at all and they're wasting the time. So it was up to them whether or not they stayed with it. And that data there I've transferred into a graph here, and you can see these changes here, you know, reading 9 out of 10 on a pain scale here, drops down to 4, and 8, just a small difference here, but 6 down to 2, 9 down to 7, 7 down to 3, small one there, 10 to 4, 8 to 2. I mean, I don't know if you know many patients like this, but this is horrible. So nice to have a tool for dealing with patients in a lot of difficulty. And for whatever reason, I've got a repeat of the same slide. Oh, no, this is a different one. Sorry, it's not a repeat. Trigeminal neuralgia, okay? Active and a placebo group. They get 5 points around the trigeminal nerve to treat. They're going to get treated once a week for 5 weeks. And what happens at the end of the 5 weeks? What's happened? This is the control group, and this is the active treatment group. And so this is one of those graphs where the number of patients at 5 weeks who had no improvement were 25% of the PBM group, but 64% of the placebo group. Okay, how many ended up with no pain whatsoever? 62% of the photobiomodulation group had no pain, just 7% of the placebo. So we can tell that this is a real effect. Placebo doesn't have a great effect on these patients. So there we go, 62% have moved to no pain. And then 1 year follow-up, a lot of benefits are lost, still 37% though, are pain-free a year later. This works differently from drug therapies. Okay, so they've gone from, what was it, 25 back to 62 a year after a course of treatment for 5 weeks, but not bad. Hey, they could just come back for more treatments. How about that? Yeah. Oh yes, postherpetic neuralgia. I said we had one on the face as well. It's a small study, just 8 patients with facial postherpetic neuralgia in a double-blind, placebo-controlled crossover study are going to have treatment over the stellate ganglion. Why? I'll show you in a minute. They're going to get treated for 3 minutes with a 150 milliwatt or a 60 milliwatt laser. This is not a lot of light, you know, or a placebo treatment. And they're going to measure forehead skin temperature, which will be evaluated by thermography. Why? I'll show you in a minute. And then they're going to measure pain intensity. So what's going on here? So it's something to do with the sympathetic nervous system and blood flow is what we're going to be treating here. And when you put a laser light in the direction of the stellate ganglion, the part of the sympathetic nervous system, and you kind of suppress it with the laser treatment, you get a parasympathetic response. Blood flow improves to the head and face, and then you get this pain relief as a result. So as it says here, sympathetic nerve impulse is blocked, blood vessels dilate, that's parasympathetic response, circulation is improved, and pain relief occurs. And a rise in temperature indicates the stellate ganglion block was successful. So it's normally done with lignocaine into the stellate ganglion. They measure the skin temperature. We got it right because the skin temperature's gone up and the pain goes away. And they did that with the photobiomodulation. So there's the stellate ganglion in there. So there's patient there's in there just above the clavicle. Squirt your laser light in there. So we do it with one of these. We've got one more cluster of lasers in here. Put it in there like that. Sort of aim it in anterior to C6. So they measure pain and skin temperature. They're measuring skin temperature just to see if you get the blood flow and they get the same type of reaction that they expect from stellate ganglion block. And sure enough, there's the placebo group, no change in pain and no change in skin temperature. The 60 milliwatt laser for 3 minutes, so a small reduction in pain, small increase in skin temperature. 150 milliwatt laser, bigger increase in, a bigger reduction in pain and a bigger increase in skin temperature. They got the same effect with laser as with a traditional stellate ganglion block, which is normally done. It's a specialist procedure done with guided ultrasound. And now a 5-year-old can do it, if you can trust a laser with a 5-year-old. Sorry, I've got a repeat slide in there, ignore that. Didn't mean to go too far. So how does laser compare with drug therapies? Here we are with non-steroidal anti-inflammatory drugs. So diclofenac, it's called Voltaren in the United States here. So this is after third molar extraction. This is one treatment immediately post-operatively. There's the control. They just had massage and ice packs. Voltaren. Here, there's a slight reduction in pain, and this is the photobiomodulation treatment group, just by lasering around the actual area of the extraction. And when I look at the parameters, it doesn't even look like it ought to do much, but still, it was better than non-steroidal anti-inflammatory drugs. And here, you only have to do it once. If you can treat immediately post-operatively, you get the best effects. This is how far can the patient open her mouth, measured with digital calipers at day 2 and day 7. Photobiomodulation group gets better. Interincisal opening at day 2 and day 7, when compared with what in the United States we call Tylenol, paracetamol, and the rest of the world, acetaminophen if you prefer. And this is not an oral one, but this is an open cholecystectomy, a gallbladder removal done with a knife. But what I like about it is it's looking at opioids, and I know that dentists have prescribed a lot of opioids in the past. So here, coproximol, I don't know if you had it in your country, it's not in the UK anymore. It's acetaminophen and opioids combined, but it was highly addictive, had to be removed from the market. They get one treatment post-operatively with the laser around the scar, and you see they take less and less and less opioids in the active group. They take more and more and more in the active treatment group, in the placebo group. How cool is that? After one treatment. Coming to a conclusion now, soon. Yes, safety contraindications and precautions. Don't stick laser beams in people's eyes. I'm sure you know that. We don't treat directly over a tumor when we're doing cancer patients, and we don't treat over a developing fetus. Sure, you can treat any other part of the body. Patients with photosensitive epilepsy, sometimes we're using light with, which has a pulse feature in it. Has this one got the pulse? Yeah, this one's got a pulse on it, as you can probably see there. So don't shine that in the eyes of patients who have photosensitive epilepsy. When you're treating extraorally, if they've got tattoos or very dark skin, sometimes the light gets into the tattoo. The ink in the tattoo gets hot, and the tattoo ink burns the patient, or gets certainly a hot, prickly feeling. Sometimes treating suboccipitally up here, you get some fine hairs, hot, prickly feeling up there. So you maybe, in both these cases, you can hold the probe away from the skin. Now, it's not with LEDs, but just lasers. Just take it like ½ an inch away from the skin. The beams diverge, they're less intense, it doesn't hurt. Yes, and some people feel worse before they feel better. And whilst we're talking about contraindications, just want to let them know that a long-term follow-up paper on head and neck cancer patients who have photobiomodulation for their oral mucositis, 108 patients followed for 8 years. Those who were in the placebo group are here. Those in the laser treatment group are there. They had better progression-free survival or overall survival compared with the placebo group. And it's statistically significant. Yes. Better progression-free or overall survival in the active treatment group if you get PBM. How cool is that? So I found another duplicate slide, you know, sorry about that. Just pretend that didn't happen. Final conclusion to this, almost. Click here. It's safe. It's non-invasive. It's non-toxic. It's non-addictive, unlike opioids. There are no known side effects. One more click. The relief is longer lasting than drugs, and it actually helps people heal. And that's why it works so well. And there's one more thing, just in case you thought this is a really cool therapy, just wait till you treat your entire body. How's that? Anyway, thank you for watching. Thank you for coming. Thank you for going. Thank you for clapping your hands. Come on, clicker. Go.